Bonjour. This is Unabridged MD. I am Isabelle Amick from Unabridged MD. I have the pleasure to have with me an incredible colleague that is specialized in fibromyalgia. We're going to learn a lot about fibromyalgia today. And I hope you're going to have a ton of hope coming from this discussion. So Martina Ziegenbein did her medical school in Slovakia in 2000. She then did a residency in Marshfield Clinic Medical Center in Marshfield, Wisconsin, that she finished in 2004. She did her fellowship in Boston Medical Center, and she followed that with a lupus fellowship at Johns Hopkins. And very interestingly, a little bit different than all of this very hard science, she went on to be a graduate of the Whole Health Medicine Institute. Currently, she sees patients at the Cape Cod Massachusetts Health Care Center. The reason we have her here is that she is a coach and she founded the Winning at Fibromyalgia. She created a podcast and she created a coaching program. I've seen some of her, I've listened to some of her podcasts, and I have seen some of the coaching that she's interested in doing and she's doing. And so I really wanted to bring her in and discuss fibromyalgia, as it is a very common condition and a lot of our rheumatology patients have it. So thank you so much for being here. I think I'm going to jump right in. Can you tell us a little bit what fibromyalgia is for a layperson?
Yes, of course. Thank you for having me. I'm very excited and honored to be here. So fibromyalgia, in layman terms, is pain all over, both above and below waist, on both sides of the body, that is by definition not accompanied by inflammation or damage or injury. That's the pure fibromyalgia. At the same time, we know, you and I both know, that many patients can have other disorders, rheumatic diseases, and coexistent fibromyalgia. So it's rarely just fibromyalgia, but by pure definition, when you have pain all over without inflammation, swelling, or damage or injury, the pain is coming from the nervous system. It's fibromyalgia.
All right, excellent. So you're a little bit of a different type of rheumatologist. A lot of the patients that we see, they know that they go from physician to physician, and no one wants to take care of patients with fibromyalgia. Can you tell us a little bit why you became interested in fibromyalgia?
Yes, thank you for that question. And, it has probably more than one reason. One of them is I have mild fibromyalgia myself in my back, so I have been dealing with this pain. Second is that what you just said about how patients come to us and tell us that whatever they were told, they may have been told correct definition, but their interpretation of what they were told was that the pain is in your head. Basically, they were not properly explained what it means. And I'm here to change the paradigm, and I'm here to change the narrative. Basically, I'm here to start patients being okay with the diagnosis, understanding what it is, and then at the same time teaching them tools how to get better. And I think that's where the kind of fracture has been, is that our role has been to diagnose or identify, does the patient have inflammatory or non-inflammatory disease? And once we identified it's not an inflammatory disease, we were like washing our hands off as if we didn't want to take care of the patient. And I'm changing all of that, because I think rheumatologists should be the one who explains to the patient so that they understand and they're okay with the diagnosis.
Okay, yeah. I mean, it's very interesting because in the fellowship I did in the US, so at Columbia University, we were not seeing any fibromyalgia patients. And in the current institution I am at National Jewish, we are not seeing fibromyalgia patients. It's always very painful for me because I feel that there's so much we can actually do. Coming from France, where I was a rheumatologist, we saw a good, sometimes up to 1/3 of our patients had fibromyalgia. And so I'm with you. I think rheumatologists should take care of fibromyalgia. I think it's just that there's so little rheumatologists that we can, and there is for people who like inflammatory arthritis like me, there's much less in a way when it comes to fibromyalgia. So to jump to this next question that I really want to ask you, and it's not just one specific question, but more. So when you have a patient that comes and has been diagnosed with fibromyalgia, what is the pathway that you're taking to make sure that it is indeed fibromyalgia and that you come up with a plan for that patient? Like, what's your process?
Thank you for asking. And I think I don't have any, like magic tricks. I do the process when a person comes to me for a second or first opinion, and I start a process as with any other patient. I talk to them, I examine them. I do run some studies if they have not had any, baseline blood work done. So the blood counts, liver, kidney function, thyroid, CK. Sometimes I do run inflammatory markers. And then, as you know, there is a lot of subtlety in how patients present. So I look for there is the overlap. There can be overlap between fibromyalgia and psoriatic arthritis / enthesopathy when there is inflammation of the tendons. So you ask, I look for that in the history, and I tell patients when I'm fairly confident, I say, I don't think there is anything else. And when there is some concern, let's say they have a history of psoriasis, they just don't have evidence of arthritis, I tell them it may take us a while, but I also tell them at the same time, I think you don't have any objective inflammation right now. If you do have inflammatory process, it may take a while. And in the meantime, why don't we work on the what seems to be neuroplastic pain? And basically, I tell them what the science shows us. I tell them the science has given us the functional brain MRIs that prove the pain is real. And that kind of settles the question that there is no question that pain is real, because that is one of the big questions of many of my patients who come for second or third opinion. They were led to believe the pain was in their head. I said, no, the pain is real. And the second of all, the pain does come from the brain. And I explained the whole thing about a functional MRIs. I don't know how much in detail you want me to go into, but basically,
I think it would be good. Yeah, go ahead.
Okay.
It would be good.
So,
yeah.
Dr. Daniel Claw at University of Michigan is one of those who pioneered functional MRIs of the brain for patients with chronic pain. I think they first worked with post-traumatic stress disorder victims, Gulf War veterans. But basically, functional MRI of the brain looks only at brain activity. And they were able to map the activity of the brain centers that correspond to pain processing centers, and how they correspond to the homunculus, the areas of the body that are in our cortex. And that's how they were able to determine without a shred of doubt that patients with fibromyalgia get those centers activated at lower levels of pressure compared to patients without. So there is something about the nervous system, brains of humans with fibromyalgia that sets the thermostat, or that sets the sensitivity level much lower, so they feel pain at lower threshold of pain. They were doing the initial studies with pressure of the thumb. Since then, multiple studies have confirmed that this can be with any pressure anywhere. So the reason I'm mentioning the functional MRIs of the brain is because they were the milepost, or the landmark that enabled the International Commission for Pain, pain classification, to recognize neuroplastic pain as the third category. So we have nociceptive pain, the pain that is perceived where there is damage or inflammation. We have neuropathic pain, and we have neuroplastic pain. So that was huge, and that's where everything starts. So I explain this concept, or I explain what that means, that people have neuroplastic pain. And then I tell them what we know. I tell them what we know and what we don't know. I tell them that medications help about a third of the patients, and almost no matter what we do. And the rest, it has to be something else. And usually patients give me an idea of how they feel about medications. I never withhold medications from them. I always offer, but many of my patients don't want medications. So we talk about what else is available. And that's where the That's where the more nebulous part comes in, where we don't have a lot of studies. We just have a circumstantial evidence to suggest that anything that enables activation of parasympathetic nervous system or healing response is what enables improvement in pain. And we can talk about that in a moment. Yeah.
I love this. I love this. There was one of my previous episodes, I talked about the parasympathetic and the sympathetic system with meditation and so on. So that's fascinating. And I do tell my patients that's part of their homework. Every single one of them, you've got to do meditation because it decreases the inflammation in your body. It decreases the adrenergic system, so you can actually heal better. I do it myself, and I can see a difference when I don't do it.
I love it. I have to tell you, we're so similar on multiple aspects, and it's so encouraging to hear that there are so many of us now that encourage our patients to do what we preach and what we practice. So
I think it probably was harder before when there wasn't that many studies, and now there is a ton of studies about the power of placebo, the power of meditation, the power of visualization, and so on. So I was personally not sharing those before I looked into the studies. And that's really why Unabridged MD is hope driven by science, because it is science-based, because we are physician and we cannot just say, hey, try this without data. There is a couple of things. One, when you share all of this science, one of them, there's two actually that I have. One is, and I think that was one of the study that really shocked me actually. That was like almost 15 years ago, if not 20. There was this study in the New England Journal of Medicine, that's like this big journal, one of the best journal in medicine, about Tai Chi in fibromyalgia, and how patients who were doing Tai Chi did much better when it came to pain. Is this something that you offer to your patient? Do you have any sort of explanation of why that works?
That's a good question. And what I talked about it with Dr. Claw when he was on my podcast. This was episode 22 and 23, I think. And basically, it's kind of, it ties back to activation of sympathetic nervous system. It's not 100% explaining why people have pain, but activation of sympathetic nervous system, the flight or fight reaction, is part of explaining how the pain starts. Then there is activation of the, inhibitory, like there are pathways that normally inhibit the pain, and they are not turned on the way they're supposed to be. And then there are pathways that are turned on when they're not supposed to be turned on. Basically, the meditative-based practices, he believes, and I agree, they rebalance these neural pathways, the neurocircuitry, in a way it was always meant to be. And that's where we miss the hardcore evidence. But at the same time, do we need to have hardcore evidence when the result is that people feel better? So the recommendation that he himself and other providers in the neuroscience field they give to patients is it almost doesn't matter which technique, which meditation-based or which meditative movement-based techniques you do, as long as you pick one, try one and do it for at least a month or two and see what results are. So Tai Chi is one, yoga is another one, Pilates another one. Yoga and Tai Chi actually have been studied in fibromyalgia. Pilates I'm not aware of, but I'm sure there is some obscure small study that have been done. Water aerobics, which is not necessarily meditative practice, but it's gentle movement based. And water is a natural environment for our bodies to move, and it also helps. And then there is acupressure, acupuncture. These are not meditation based, but they are Eastern techniques. We don't exactly know how they work. Like we don't have all the, every step of the way figured out, but it helps in some patients. So why not? It's safe and it helps. So I don't put restrictions. Like I should take it back. When patients ask me, it is my role to tell them what I don't consider safe. For example, there are things like PRP, which costs $5,000 to $10,000, and we don't really have, like, it's not necessarily harmful, but we don't really know that it helps fibromyalgia. So I tell them, like, we don't have evidence right now. I can't stop you, but here are other options that you can try before you go down the expensive, non-reimbursable route. So I always point them in the route, in the course, in the realm of evidence-based, but at the same time, I open a little bit for their interpretation. And then I talk about the meditation or mindfulness-based practices that were studied from a little different angle. I was going to mention in a moment.
Mm-hmm. That's fascinating to me. So it's very interesting because it hits home right now about the pain that, like, you can actually take care of the pain with meditation. And so I had this example, and I want to share it with you because I was blown away. First of all, I'm reading this book called The Brain's Way of Healing by a physician called Norman Deutsch. It's fascinating. I mean, like how you can actually help Parkinson with some sort of exercise and meditation based practice, how you can help pain, chronic pain. And so I was reading this book, and then one of my friend I've given me her cat, and it's her baby, like, and the cat is young, and we opened the door by mistake. She escaped, and so I finally found her in the neighbor's house, and she doesn't really know me, and so I tried to grab her, and she started biting and hissing and scratching. It was awful, but I was like, I'm not letting you go because you're my friend's baby, and I'm not letting you go, right? And it was awful. So I went to the emergency room because I was like, I thought that maybe I would need stitches, and I was like, I need this to be clean. Like cats, it's awful. And I started having the pain. Once the stress level went down, I started having severe pain, and I started meditating. No more pain, just gone. And, the moment I would stop meditating and I would be like, oh my gosh, I hope I'm not going to get an infection from this. I hope I don't have to get that the tendon is not severe on my hand and so on. But the moment I would meditate again, it would go away. And I'm like, wow, that is so powerful. So powerful.
That is I agree, it's a very powerful story, but that you mentioned the catastrophizing or awfulizing. So there is evidence that certain characteristics, like certain people, certain characteristics of our nature do predispose us to pain, and catastrophizing, people pleasing, perfectionism, and worrying are the four most frequent ones that do lead to worsened pain. There is a questionnaire that Dr. Claw uses at in his research studies. I will look it up and I can send it your way. That kind of addresses. Then they call it fibromyalgia nest. They don't only ask about pain, but they ask about depression, their sleep, and the other characteristics that predispose people to having more pain. And it's really important to know that about persons, because he said it can make a difference, like for somebody who is going for surgery, and depending on that score, how high it is, they can determine how much narcotics they will need after surgery. It's fascinating stuff. And I'm in the category of people who and that's what I'm learning not to do. I'm learning to change my ways, the catastrophizing, awfulizing, worrying, perfectionistic traits.
It's really interesting because I was okay until I realized that, and the people who are listening to this podcast and YouTube videos, they know my story, right? So I was okay, and I did a meditation until I realized, I was like, oh, it's the arm where I got my mastectomy and the lymphadenopathy were removed, and I had a little bit of lymphedema for several months, and I was like, holy moly, this is not good. I have more risk of developing infection. So I was like, no, the power of the mind. And I put my arm in betadine, and I was like on antibiotics, and I was like, I did, Qigong and healing. And I was like, I'm taking everything on my side right now. I am not I don't want to go to the OR with an infection. But it's funny
because sharing.
Yeah.
Good for you. I'm glad I'm excited that you know how to do it. I will then listen to your episodes and learn or recommendations on how to learn Qigong. I haven't mastered that yet.
Oh, it's very cool. Yeah, yeah. I mean, I'm gonna bring Qigong, my Qigong master on the channel because she has. I mean, I feel like she really saved. I don't know if she saved my life, but she saved my sanity. I would say that because I had support and so on. And it's true that catastrophizing. It doesn't help. That's the bottom line. It doesn't help. So you're using a lot of energy. And I keep telling this to my patients. I ask my patients to visualize. I don't tell them that they're going to be better. Though sometimes I do because I believe it. But I always tell them I want you to start visualizing yourself healthy. What does that look for you? You know, like what does healthy looks like? What will you do? Start imagining that it's today. And if it's today, how do you feel? And there is studies on that.
I
There's
love
studies.
that. I
Yeah.
love it. And that's actually, it's a good segue to what I was going to say next, which is I always, so after I explain the science, I always tell patients that one of the most important prerequisites for getting better from pain is believing. First of all, believing that embracing the concept of neuroplasticity, that brain can cause pain. Number two, believing they have it, because you would not believe how many patients come to me and they get better when they start believing they actually have the diagnosis. They come questioning what else they might have. And once they accept the diagnosis and understand it, but then the third part of it is believing you can get better. So what you just said, believing you can get better is like number one condition before you can get better. And I had so many occurrences when I didn't do anything. I just saw the patient for the first time. I ran some tests, and then I met them for the second time 1 week later to go over the testing and summarize everything. And they already told me they started feeling better, just knowing, like,
Yes.
having only the first encounter, reassurance, and like permission to believe that they can get better. It's fascinating. And I compare
Yeah.
it to like the 4-minute mile, right? Before the guy who ran, Roger Bannister, he ran the mile in 4 minutes. Nobody did that. And he believed and did. And that's exactly the same with rewiring our nervous system. So
Oh, yeah. Yeah, it's really interesting that we are in the same, length wave on this. Going back, I want to go back because in another type, so we're talking about the brain and how the functional MRI have helped learn that it was coming from the brain. However, there is also, and there is also patients, a lot of the patients that I see, for example, since I don't see a lot of fibromyalgia, they come and they have rheumatoid arthritis, they have Sjogren, they have lupus, right? And they are also diagnosed with fibromyalgia. And I always question it because I'm like, well, how about if this is small fibers neuropathy? Do you see a lot of patients in your practice that actually have small fibers neuropathy? Because that's coming from the nerve. Then it's coming from absence of nerve ending.
I just want to clarify. You said small fiber neuropathy, or which neuropathy did you
Small
say?
fibers neuropathy. Yeah. So and so it comes down, like, historically we realized, and I was part of a study a long time ago where we found that patients with rheumatoid arthritis and Sjogren, they had more fibromyalgia, and more we're realizing that this is not fibromyalgia and it's small fibers neuropathy. And the small fibers neuropathy, basically, if you do an EMG, it's normal, and if you take the biopsy, there's less nerve ending. And I find it has to come from the brain, actually, because there's less nerve ending. So that, like, what do you think of this?
Yes, thank you. And I don't think I will give you, I always am careful to say black or white or 100% answer. I asked that question, Dr. Claw, and he said that in their opinion, so in their hands, they felt that small fiber neuropathy, basically decreased density of the nerve receptors in the skin, is actually a way of the nervous system self-regulating, as if it was trying to decrease the amount of receptors that can cause pain. And I thought it was a fascinating look at it because it does make sense. The functional MRIs of the brain, I know we were talking about the small fiber neuropathy, which is peripheral, but the functional MRIs of the brain show in patients that parts of the brain shrink and other parts of the brain get bigger in response to chronic pain. So as if the nervous system was trying to self-regulate itself. I mean, there is a lot of unknown, but whenever I have a patient who have numbness and tingling, we do a little bit of testing. And I remember like the most striking example of this was this patient had severe numbness and tingling and burning in both his hands and feet. And he told me it goes completely away. And he says, completely, I can sleep when I take Halcyon or anxiolytic. So you know that it's not, pathological. You know that it's related to nervous system activity. If it goes completely away with an anxiolytic, you know that it's not pathological, or that there is no significant pathology. But he wasn't willing to accept, and he has so much significant trauma in the past, psychological trauma. And I thought it was clearly connected, but the reason he wasn't willing to accept that he had fibromyalgia is because to him, it wasn't macho enough. It wasn't manly enough for the brain to cause pain. And that's one of the messages I teach my patients, is that there is nothing wrong with you. The brains are wired to look for danger. And one of the ways to express the threat or to respond to threat is by causing pain. And I always compare it to like, everybody accepts short-acting, short-lasting sympathetic nervous system activation. For example, I blush when I'm embarrassed, and I blush for like 5 minutes, but then it subsides, right? And I said, everybody sees I'm red, but there is nothing wrong with me, right? It's just a reaction of my skin vessels to the embarrassment. The threat level then decreases, or whatever caused the embarrassment, and my flushing goes away. I said the same thing happens with pain, except it's more chronic. It's not self-limited. And people who accept that, I find, have more success in pain reduction, because they're more open to investigating other avenues for pain reduction. They don't just rely on medications.
Yeah, very interesting. So could you tell us, this podcast and this channel is about hope, how we bring hope to our patients. I'm a big believer that every time you go to the doctor, at the end of the visit, you should have hope for your care, hope for where you're gonna go. And so, do you have a case that would embody this?
I do actually want to, I have had so many patients. I have been doing it, or I have been embracing my love for fibromyalgia for the past 8 months. So I have been doing it long enough that I know that it's not a fluke. So somatic tracking is one of the exercise, or one of the tools I do with my patients. And I want to share with you what actually happened just today. And it was so powerful, so endearing. I had a patient who needed an interpreter. This was our second visit. I saw her first time a couple of weeks ago, and she has both Sjogren's with a lot of dryness in the mouth and eyes, and fibromyalgia, especially with back pain. And so there were two concerns. She had a concern about Sjogren's, and nobody has explained to her that she doesn't have to die from Sjogren's. So that was a shock, first of all. She was very relieved. And then nobody has ever explained to her what fibromyalgia means. So we went slowly, with interpreter help. So she was like, you could tell that she was putting things together. And then we did somatic tracking. And somatic tracking is a mindfulness-based technique when you bring attention to the pain now without judgment, and you send safety messages to the brain. And it was all slowed down because I had to go through the interpreter. So I could watch her more, I could observe her, and you could tell she was really listening, and she was trusting me. She was letting the words hit her. And as I was speaking the words about how she's strong, how she can handle any pain that the brain sends her way, she started crying, and she said, "Oh, and my pain has gone right now. The pain has decreased so significantly." She was able to tell a difference. And then I did explain to her it may come back, but this somatic tracking, this mindfulness-based technique, you can do every day on your own, and this is all you. And when it was words in combination with deep breathing, closing her eyes and being completely non-judgmental with the pain. And when she heard that, it was such a beautiful moment, and you could tell that she believed me, and she believed that she had hope, like that she had good chance of improving and changing her trajectory. It was, and that's the moments I live for. I'm still employed, and as you pointed out, employed medicine can be very hard, but these are the moments I live for, when I can deliver what we are really here for as physicians: explaining, examining, explaining, giving people explanation, and giving them tools and hope, like giving them evidence that they can take every day to home. So that was the example. And basically, I was gonna say, there is nothing wrong with you. If you have fibromyalgia, there is nothing wrong with you. It's your nerve cells in your brain misfiring, and you have 100% chance of making it better. And I know it because I did it. Many other people have done it, and you just have to have faith and patience.
That's a beautiful story. I think it empowers what I think of Unabridged MD, what I think of good medical care, like empowering a patient. It's not just about drugs. It's not just about, this is it and that's it. I'm not seeing you for 4 or 5 months, but really just like, okay, let me make sure that you understand what I know, so that you can be empowered to do, to take action to get better. So thank you so much for this. Where can we find you? And is there anything else you would want to add to we are coming to the end of this half hour.
Thank you so much for having me. Thank you for doing what you're doing. I really think it's amazing that you're doing that. This is what we need more of, and I'm very grateful that you thought of me to have you here. That's to have me on your show. Second of all, I really truly believe that each of us with fibromyalgia, we can harness the power of our brain to use it for ourselves. I have no doubt. And I want to be there I want my message to reach everyone. I can be reached at www.winningatfibromyalgia.com. I'm also on Instagram, and I don't remember I will have to submit it to you later. But I'm on Facebook, I'm under Martina Lenartova, and I have a Facebook closed group called Winning at Fibromyalgia. If you're interested to join, if you're listeners, you just have to send me a message and you'll be approved.
That's absolutely beautiful. I like to give exercise every week. I have forgotten a couple of times, but I'm going to do one, which is believe. We've got to start, all of us, to believe that we can get healthy, and that it really is an important thing to believe. And just starting very closely with okay, I'm going to believe that I can find someone like Martina Ziegenbein, or Lenartova, depending if we're on Facebook. But yeah, so it was an absolutely pleasure to have you. Again, so I'm Isabelle Amig. I'm from Unabridged MD. Please like, comment, subscribe, share. Those are for you. If you have any questions after this episode, please comment, and we will have Dr. Martina bring and give us the answers. And if you have any other question, if you want Dr. Martina Ziegenbein come back, let us know. We will. And again, thank you so much. Thank you so much for the work you do. It is so needed out there. So thank you.
Thank you. Thank you.
Have a wonderful day. Bye-bye.